Well, I want to thank everyone for joining us for tonight's webinar, Emerging Technologies, sponsored by the COC Committee of the Florida Chapter of the American College of Surgeons. My name is Dr. John Rioux, and I'll be serving as tonight's moderator. I'm a cancer liaison physician at my hospital. I'm the Florida State Chair and also the Chair of the Florida Chapter's Commission on Cancer. A few housekeeping notes. This webinar is eligible for CMEs as well as American Board of Surgery self-assessment CMEs, and if you stay till the end of the webinar, you'll be automatically redirected to an evaluation website where you'll be prompted and take a short test, and you fill out the activity evaluation and generate your CME certificate. If you're not redirected to the claim credit system, then don't worry, we'll send you an email tomorrow with the evaluation link. So for tonight, the objectives of the webinar are to review the newest technologies that facilitate improved patient care, outcomes, and surgery. Joining me tonight is faculty, Dr. Nicholas J. Panetta, MD, FACS, Assistant Professor, Department of Plastics, University of South Florida in Tampa. J. Redan, MD, FACS, Professor, University of Central Florida, Chief of Surgery, Florida Hospital Celebration Health in Celebration, Florida. And finally, Dr. Ali Kasraeian, MD, FACS, Kasraeian Urology in Jacksonville. So we're going to take some questions after we get through all three of the faculty presentations. Questions can be typed in the Q&A box on the right of your screen, and we'll try to respond to as many of these as possible. So without further ado, let me introduce Dr. Panetta. Again, Nick is an assistant professor of surgery at University of South Florida Morsani College of Medicine and also faculty at Moffitt. Nick established the USF Health's and Moffitt Cancer Center's comprehensive program for the management of lymphedema. He had completed, among other things, a research fellowship at Stanford, and I'm sure his topic tonight is going to be of interest to all of us who've had lymphedema patients. So without further ado, Nick.
Thank you so much for the introduction, and thank you very much for the opportunity, guys, to present to you tonight about some exciting stuff we're doing working towards making improvements in the care of what we all know to be a very challenging patient population. Historically, I've had an opportunity to see this kind of on both sides of the coin as a general surgery resident trainee, being faced with these very challenging issues after we had treated patients' cancer, but not really having much to offer them in the form of treatment of their lymphedema, to now working towards making some progress using some new techniques that we have available to us now from a microsurgical standpoint to identify disease early, intervene with microsurgical intervention on early known disease. And what we're really focused on now is working towards intervening at a point where we might be able to have the opportunity to really reduce the incidence of this in a global fashion. Nicole, you can go ahead and advance. Great. Just want no disclosures tonight as part of this talk. Basically, as an overview, just want to kind of give a basic overview of the disease process. We're all pretty familiar with that, so we'll go pretty quickly there. Understand what the role of non-surgical modalities are. These are historically things, complete decongestive therapy that we've offered patients because that's all we've really had to offer. And there still is an important role in controlling fluid in cancer-related lymphedema patients for these modalities. But really, I want to focus on how new surgical techniques and especially newer imaging modalities that we have available to us now have allowed us to develop more targeted surgical interventions to really mitigate the effects of these disease processes. Next slide. So, this is an interesting quote that a patient said to me about 6 months ago, and I think it really imparts kind of a message that how profound an impact this disease has on patients. And so this patient, she's sitting there in clinic with me, and she had really some pretty bad complications related to radiation and the surgical treatment of her breast cancer, and it left her with a paralyzed right hemidiaphragm. And she says this to me: I have a paralyzed right hemidiaphragm from treatment. I'm short of breath every single day. And then she follows that up with, but it's this arm that's really the worst part of anything that's happened to me. And I think that's just really a profound statement in what we have to do to try to help these patients and how it really hasn't gotten the attention it's deserved historically. Patients all show up to clinic. End goal for these patients is they don't want to wear these garments anymore, especially here in Florida. They're miserably hot all the time. They just struggle with compliance here. And so we really need to work towards doing something better. As far as demographics, we all know that cancer-related treatments is the main cause of lymphedema in this country, related to disease burden, extent of surgery, and adjunct therapies that we'll touch on a little bit more. But what we're learning in treating this disease pattern and from some of these targeted real-time imaging techniques that we have available to us is that there's significant patient variability in lymphatic anatomy. And I think this is where we're working towards getting a better understanding of this and being able to predict which patients are going to develop lymphedema in the future and focus our preventative strategies in this patient population. We know that this disease is progressive. There currently is no cure for this. Patients are really tortured kind of with this disease once it sets in. Heaviness, fullness, decreased mobility are things they deal with every day. And then the hospitalizations and the costs associated with those hospitalizations from cellulitis, lymphangitis, and the progressive evolving pathology that's associated with this. Next. We know this does indeed impart a significant cost to the healthcare system in this country. The Stanford Center for Lymphedema did a very nice study on this, broadly looking at patients affected with cancer-related lymphedema over time, and identified that it's associated with a greater than $50,000 per year cost for patients who carry this diagnosis. And we know that the prevalence of this, despite our goals to reduce axillary interventions and reduce the incidence of treatment with radiation therapy, the overall incidence of cancer-related lymphedema has continued to climb. So really stimulating an increased need for better interventions. Our focus largely in getting started with some of our preventative measures has focused on breast cancer-related lymphedema. However, this can be broadly applied, and we're starting to look at this in other cancer-related lymphedemas as well. Those associated with GYN and GU cancers, melanoma, sarcoma. We know that broadly at-risk patients are those who have underwent lymph node dissections, have nodal disease at the time of presentation, adjuvant radiation therapy, neoadjuvant chemotherapy, and obesity. What we have learned from a plastic and reconstructive surgery standpoint is that the type of reconstruction these patients in the breast cancer patient population undergo does not affect their incidence of developing lymphedema in the future. A busy slide here. Lots of staging mechanisms have been proposed to classify lymphedema. The International Society of Lymphology is a broadly accepted one. And the important thing to take away from this slide is really the differences between stage 1 and stage 2 lymphedema. Stage 1, we still have reversible disease, and these patients are going to be afforded a better opportunity to have a significant benefit from the microsurgical interventions that we're offering today. Stage 2 disease, the probability of gaining a benefit from the microsurgical interventions that we can afford them starts to go down due to the significant damage and lack of preservation of underlying lymphatic function. So the goal here is really developing high-risk monitoring algorithms that lead to early diagnosis and subsequent early intervention. Next. What is going on here at a physiologic level? We have an initial lymphatic insult. Subsequently, the vicious cycle of lymphedema ensues, where we get an accumulation of interstitial protein-rich fluid. This leads to a chronic inflammatory state, lymphatic vessel smooth muscle dysfunction. Subsequently leads to an initiation of fat fibrosis, collagen deposition, leading to progressive lymphatic dysfunction, progressive fluid accumulation, and the vicious cycle goes around and around. Again, indicating why early intervention, which is a theme here kind of, is really an important factor that we need to be considering. And it's really why we need to do something better here than what we've had to offer patients previously. What have we historically offered patients? Well, it's largely what we know as comprehensive decongestive therapy or complete decongestive therapy. But really, no pun intended, it's a Band-Aid. It's just a Band-Aid on the underlying problem, really. If you look at this list of things that we ask patients to participate in treating their lymphedema historically, patient compliance is a major, major problem, as it would be for any of us. We can list these things out, but if you actually consider the implications of doing daily compression, daily wrapping, dealing with daily skincare regimens that are pretty invasive, pneumatic compression devices, this would be hard for anybody to manage on a regular basis, which is why in a short order, most patients fall off being reliably diligent in doing these things. And so this leads us to having to develop a better way to address these issues. Next slide. Is CDT effective, complete decongestive therapy? It is. It is, but it doesn't represent a durable answer over time. It doesn't address the underlying anatomic pathology that has been created by disrupting the regional lymph node basin. And as such, we've looked to surgery to come up with a better answer. Next slide. Historically, treatment of chronic lymphedema has been attempted through what we all know to be very, very morbid procedures. Patients used to present, and still occasionally will present to our clinic with disease that's progressed to this level. And so at this point, obviously, no microsurgical intervention is going to produce any kind of a useful result for these patients. Historically, excisional techniques were utilized here. We know this to be, again, a very morbid approach to treating this disease. When patients like this present to me now, certainly suction-assisted lipectomy is a technique that I utilize frequently, large volume suction-assisted lipectomy, to reduce the accumulated adipose tissue and fibrosed tissue and simply provide them symptomatic relief. But we're not looking to give them any kind of a meaningful, durable cure here. As such, we really look to, next slide, address identifying patients in an early fashion and addressing these patients with microsurgical intervention today. In order to know, though, which patients we really want to be targeting appropriately with microsurgical intervention, we've been able to do this by some of the newer imaging techniques that we have available to us today. Here we see a very image of what used to be lymphangiography, where the lymphatics were directly cannulated and the lymphatic system was imaged. But this is a pretty invasive technique and is largely just of historical significance only. The main thing we're utilizing in evaluating these patients today is lymphoscintigraphy, which I'll talk a little bit more about, and its role in the workup of these patients, and near-infrared fluorescence imaging, which has really been a game changer for these patients in the diagnosis and treatment of these diseases. Lymphoscintigraphy is important, and the way we use it in our clinic is its role in preoperative decision-making. What it allows us to do is gain gross information regarding regional lymphatic drainage. We can know after lymphoscintigraphy whether or not there is any capacity or preserved underlying lymphatic function that allows for lymph fluid to still make it to that axillary lymph node basin. If that is the case, we know we're still able to potentially reroute the plumbing down in that arm using some of our microvascular surgical techniques that'll afford these patients a benefit. However, if we don't see any drainage at all, if it's just diffuse dermal lymphatic uptake on a lymphoscintigraphy, we know we have to be looking towards some of our other surgical techniques other than lymphovenous anastomosis to treat these patients, as that procedure's efficacy is going to decrease significantly. Once we know a patient we think has adequate preserved underlying lymphatic function, we then have available to us, which is a relatively new tool in the scope of treating lymphedema, and that's near-infrared fluorescence imaging. This has historically been used in other surgical applications such as cardiac output monitoring, hepatic function and blood flow monitoring, and more commonly in breast surgery and plastic surgery for the monitoring of perfusion of flaps. But here it allows us to evaluate in real time lymphatic anatomy and identify targets for microsurgical anastomosis. Next slide. This is what lymphatic imaging grossly looks like when we do it, moving from screen type 1 on screen left there, where we see linear lymphatic flow by ICG imaging, and we'll see a video of what this looks like in just a little bit. Progressive, as disease progresses, moving to the right, where we see diffuse dermal backflow and uptake without any flow in the deeper lymphatic system. So what we're working towards is identifying patients excuse me, with early stage lymphedema, both clinically and by imaging techniques, so that we know they have some preserved underlying lymphatic function that's going to increase the efficacy of our microsurgical interventions. Next. A couple of mainstays of microsurgery that have evolved in the past several years are, again, the lymphovenous anastomosis or lymphovenous bypass technique that is our focus of early intervention at Moffitt and the mainstay of my practice, as well as vascularized lymph node transfer, which is looking to impart a capacity for new lymphatic development. But if we're at that point, we're looking at a disease state that's more progressed. So we're looking to intervene earlier than that. to expand a little bit more about lymphovenous anastomosis and its role in intervening on earlier preclinical disease and the prevention of lymphedema. This is a concept that was modernized by the Japanese back in 2000, Kashima and his group. And what the concept is here is that it reestablishes drainage in regions of dermal lymphatic stasis. So the idea here is to identify specific targeted lymphatics on an affected extremity and simply connect those to veins on that arm, providing an alternate route of outflow for the lymph fluid. These anastomoses are very small. They're performed from lymphatics, subdermal lymphatics to venules on the order of 0.3 to 1 millimeter in diameter. And as again, we know that these operations function best in early stage lymphedema, where the underlying lymphatic function is still preserved to a certain extent. And we know we'll have some functioning lymphatics to continue to pump that fluid into our venules down on the extremity. Next slide. How efficacious are these? Well, over the past several years, we've learned that indeed they work quite well. Both the Penn group reported a large series, and Dr. Chang at his time at MD Anderson and now at the University of Chicago have had results early on that we have had very consistent results with at the Moffitt Cancer Center. So, we don't promise any of these patients that reliably they will get out of their garments. But what is interesting is that almost all of them, and what has proved to be a significant benefit to patients, is that get relief from their subjective symptoms. Those feelings of heaviness, fullness, tingling in the extremity go away for almost everybody. Next slide. And that from an objective volume standpoint, what we know is that patients are able to achieve anywhere from a 30 to 40% reduction in their preoperative volume. Now, these are in patients with established lymphedema. And what we're working towards now is applying these techniques in patients with preclinical disease to see if we can mitigate the progression to clinical disease whatsoever, and also applying this lymphovenous anastomosis technique in an immediate fashion at the time of axillary nodal extirpation to see if we can prevent the disease altogether as well. Next slide. So this is our opera. Nicole, if you can go ahead and advance again. Oh, I'm sorry. Back a slide. Looks like we might have a little bit of a formatting issue here in transferring this from a Keynote to a PowerPoint. But the takeaway from this slide, and really our algorithm for approaching these patients, is when I think about patients presenting to our clinic, I separate them out broadly into early stage, moderate stage, and late stage disease. Early stage disease, the primary component of disease is accumulated fluid. Moderate stage disease, we're looking at more loss of lymphatic function, and late stage fibrosis and adipose hypertrophy, and this is where we're wanting to avoid. So we're trying to identify early stage patients where fluid is the major component of the disease, and lymphovenous anastomosis, as opposed to other surgical interventions, is going to be our mainstay of therapy, because it's here where we can make the biggest difference without some of the other downfalls of both progressive disease as well as some of the other surgical interventions that are performed for lymphedema. Next slide. At Moffitt, this is just going to be a brief overview of our approach to these patients. Once patients are identified as high-risk patients, they are then enrolled in our multidisciplinary lymphedema clinic for ongoing monitoring and screening. These patients are evaluated at 3-month intervals out to 2 years. And if any evidence, either subclinical evidence by LDEX screening, looking at fluid differentials between the extremities, or clinical evidence of lymphedema is identified in their screening evaluations, additional workup is initiated so that we have the opportunity to intervene at an earliest stage as possible, and potentially intervene with surgery when appropriate. Next. Preoperative assessment of these patients includes, still I mandate that they're all compliant with complete decongestive therapy before surgical intervention. This is still an important part of controlling their fluid leading into their surgery. It involves a focused physical exam to both clinically stage the extent of their disease and gain a better understanding of whether or not I feel clinically they're going to be a good patient who's going to get a good result from a lymphovenous anastomosis procedure. And again, imaging in the form of lift scintigraphy to define the preservation of underlying lymphatic function. Next slide. And so here, I just want to give everybody a sense of how the procedure actually evolves in someone with early stage lymphedema. Nicole, if you can play that video. This is what's involved in performing the ICG imaging intraoperatively. It's about a total of a tenth of 0.25% ICG solution that's injected into each of the digital web spaces. And this is before we begin the operation at all. We perform this imaging to identify our targets before any surgery is performed. So this is being performed in the operating room. Next slide. And if we can play both of these videos here, what you can see is this is what ICG lymphatic imaging looks like in the operating room. So you can see on screen left, we have just white light. This is me performing some gentle lymphatic massage, paired with what this looks like underneath the ICG imaging camera. And you can clearly see the linear lymphatic channels distal to the area of obstruction that allows us to identify where we're going to make our incisions, target our lymphatics for lymphovenous anastomosis. Great, and this is what this looks like after we've performed our imaging. Our target lymphatics are identified, and we began the procedure. Next slide. This to just give a sense of quickly the scope of what we're dealing with here. The center suture is an 11-0 nylon suture. This is what we're using to suture these lymphatics together, avoiding some of the difficulties that people have had historically in doing with this. So the goal here is that you have to suture these lymphatics to very, very small subdermal venules to avoid the issues with venous back pressure that have led some of these procedures to fail historically. And so moving on, I just want to show a quick video of what this looks like when we're performing this. So this is a lymphovenous bypass procedure on a patient with stage 1 lymphedema. Procedure begins with approximately, first of all, I should say, initially, we inject the incision with just a little bit, approximately a cc of 1% lidocaine with epinephrine to assist with hemostasis in the dissection. Additionally, after we've mapped our target lymphatics, we inject just distal to our incision a little bit of methylene blue, which helps identify the subdermal lymphatics when we're under the scope. Retracting sutures are placed using some 6-0-proline, and then dissection is carried down into that subdermal plane, and this is really the plane that we're looking for to identify our lymphatics. Once we've identified our lymphatics in an appropriate recipient vein, these are both prepared, lymphatic being clipped proximally and the vein being clipped distally. That's usually the orientation we approach this in an end-to-end anastomosis fashion. And then again, this is all done with simple interrupted sutures. 11-0 sutures is usually what we're using to do this, anywhere from 2 to 4 sutures to get good coaptation of the ends of the vessels in a tension-free fashion. This is just a view here of us bringing on screen left the venule together with our dissected lymphatic, screen right, and the anastomosis being performed. So an important last step after you've done this, obviously, as with any vascular anastomosis, you want to confirm the patency of what you've put together. And that's no different when things are very small as well. So before we close, the scopes that we use actually have integrated ICG imaging cameras on them. And so what we can do is inject a little bit of ICG contrast just distal to the incision. And here we can see screen left, the anastomosis we've performed under ICG imaging, and on screen right, a comparison in bright light, just confirming that we have good patent flow of contrast across our anastomosis, ensuring that we have a good patent anastomosis. Next slide. This is what it looks like when we're done. Several incisions, anywhere from 3 to 6 is what we typically perform in a patient. These sutures are removed the following week. And then we follow these patients in lymphedema clinic at the prescribed time intervals of 3 months. And this is a result that can be expected at 1 year. This is a patient 1 year out from their lymphedema surgery. They have had resolution of their swelling. They're no longer wearing their compression garments, and this is the type of home run result we're looking for. Obviously, not all the patients undergoing this procedure are getting this kind of result, but that is certainly what the goal is and what can be achieved with the procedure. The complications are rare. Infection, wound healing issues, lymphatic fistula is reported, but not something I've experienced in practice. Next. And how are these patients monitored postoperatively? Historically, we did this 24-hour observation, and honestly, most people are going home same day now. They do compression wrapping, not their compression sleeve, for a month afterwards, just so they're not pulling these things apart as they try to get their tight compression sleeves on. Result for an upper extremity can be achieved over the first year, and lower extremity over the first 2 years. Patients continue to appreciate improvement following the procedure. Next. How do we monitor these patients post-operatively? A variety of methods have been discussed. What we've implemented in our clinic is a combination of circumferential limb girth measurements and bioimpedance spectroscopy. And the reason I focused on this is I think the goal here should develop a reliable screening mechanism that's as broadly expandable to the community as possible. You know, at a lot of tertiary care centers, sure, certainly these other modalities can be implemented on a regular basis, but largely they're cost prohibitive. And so I think the goal and what we're trying to work towards is have a system of monitoring that can be applied really anywhere in the country by having a trained lymphatic therapist, as well as a relatively inexpensive piece of equipment, which comes in the form of our LDEX equipment or to perform bioimpedance spectroscopy. Next. And so where are we going with all this? A final step is really restoration or preservation of functional lymphatic anatomy to avoid the development of this disease altogether. Toward this end, as I've alluded to a couple of times, does timing of diagnosis matter? It certainly does. And this is where LDEX and careful screening in our lymphedema clinic plays a key role. If you can identify this disease early, as the Pittsburgh group eloquently put forth, and intervene both with decongestive therapy and surgery, potentially, you can significantly reduce the progression to clinical lymphedema. When patients were identified by LDEX, their monitoring in Pittsburgh and intervened upon before the development of clinical lymphedema, as opposed to traditional monitoring algorithms, they were able to reduce the progression to clinical lymphedema from 36% down to 4%. So clearly, stage matters when your diagnosis is made. Next. And stage at the time of surgical intervention matters as well. You know, we're looking again to intervene on patients with stage 2 or with stage 1 or early stage 2 disease. We know that patients intervened upon at this point have a significantly better outcome long-term than patients with later stage disease. Next. So how can this all be applied to the prevention of breast cancer-related lymphedema altogether? Well, the goal here and what our current work is focusing on is the preservation of extremity-draining lymphatic structures. Reverse lymphatic mapping is performed in that extremity through the injection of isosulfan blue of microsurgical lymphatic targets in the axilla in conjunction with the breast surgeons at the time of axillary nodal extirpation, preservation of those lymphatic structures, and then microsurgical reconstruction of the draining lymphatics at the time of surgery. You know, crossover drainage or clinically suspicious nodes should dictate removal for sure, as opposed to lymph node preservation that is being performed at times to isolate and preserve arm draining lymph nodes. And the procedure should really be reserved for patients with known axillary disease requiring axillary lymph node dissection. Next slide. So we can kind of briefly look through this, and I'll fast forward, but really it's a very similar principle that was applied to established disease node lymphovenous anastomosis for lymphatic reconstruction at the time of nodal extirpation. This is the dissection out of an axillary draining lymph node at the time of axillary lymph node dissection. So it again is isolated. A recipient vein is identified in the axilla. And again, a microsurgical anastomosis is performed to reconstitute lymphatic outflow from that extremity. Again, anywhere, and I'll mention this a bit in a second, I think that learning more about lymphatic drainage patterns in an arm is going to be critical here. What we're starting to identify is that there are certain patterns of lymphatic drainage. Some people have a dominant lymphatic channel that drains that extremity, whereas some people have more of an arbrized pattern of lymphatic drainage. So that leads us right now to perform anywhere from a single anastomosis to up to 6 lymphovenous anastomoses at a time when we've done this in an immediate fashion. Nicole, you can go ahead and fast forward for time's sake. Go ahead and click to the next slide. There we go. So where are we at in achieving this with our immediate lymphatic reconstructions? This is a representation of our early data. We've now done this in 29 patients as of now, where we've performed lymphatic mapping and immediate reconstruction. 2 patients out of this group were excluded. Our mean follow-up is just less than 6 months right now. Average age was just over 50 years. BMI is not a contributing factor here. It's all patients on average were less than the BMI of 30. Adjuvant radiation was in 52% of patients, neoadjuvant chemotherapy in 3/4, and adjuvant chemotherapy in 1/3. The mean number of anastomoses we performed was almost 3. Next. And so what we've appreciated at this early time point is 3 of 25, 8% of patients with post-op lymphedema. Now, we understand that this is early data, but this does represent a significant decrease in what would be expected in this patient population. LDEX monitoring post-operatively is in the normal range, and there have been no subjective or objective exam evidence of lymphedema in these patients who have been successfully treated. And there's been good correlation between our LDEX numbers, looking at fluid differences in the extremity, and subjective symptoms that patient report. Next. And so where are we going with all this? And as I alluded to a moment ago, I think as the more we've done this, I think it's going to be important to define the anatomy or come up or further establish an anatomic classification of lymphatic drainage of the upper extremities. I think this is going to provide us some information with regard to who is at highest risk for subsequently developing lymphedema. And broadly, what I've started to classify these as is type 1, type 2, type 3, where a patient has dominant lymphatic outflow, a mixed picture, or what I'm calling arbrized lymphatic outflow, multiple small lymphatic channels draining an extremity. I do think that we're going to be able to show here that it is those patients with dominant lymphatic outflow, a single channel draining the extremity, or 2 dominant channels that are at highest risk for developing lymphedema postoperatively. And the goal would be, through our imaging techniques, to be able to establish who these patients are preoperatively and intervene in a targeted fashion. So what are the important points to take away here? Close monitoring of at-risk patients is key. The importance of establishing expectations for intervention cannot be overstated. Preoperatively, these patients need to know that this is not a magic bullet yet. There is no guarantee that this is a cure. Imaging is critical to appropriate targeted surgical intervention. And regarding microsurgery, and Nicole, if you could just advance one more time there. Early diagnosis equals functional lymphatics and minimal fibrosis equals successful intervention. What we don't know is a lot right now. Where anastomosis should be performed, how many is critical to having good success, how much damage to the lymphatic system is too much to successfully intervene with microsurgery. And so we're working towards answering all of these questions. Next slide. Just obviously working right now on prospectively studying this, both our immediate lymphatic reconstruction as well as intervening in preclinical disease to determine and define our efficacy in preventing progression of disease, as well as what measures are going to be best utilized to monitor these patients postoperatively. Next. And just some acknowledgments to the people that are really critical in helping make our multidisciplinary clinic move forward at Moffitt. Thank you very much, everyone.
Very good, Nick. So let's move on to Dr. Redan. Jay Redan's professor of surgery at the University of Central Florida, and he is also medical director of minimally invasive general surgery at Florida Hospital Celebration. Dr. Redan has held leadership positions in essentially every important laparoscopic and Minimally Invasive Surgical Organization, and is a charter member of the Society of Robotic Surgery. He is widely published and is an acknowledged thought leader and subject matter expert in the field of emerging surgical technology. Jay, take it away.
Okay. Well, thank you very much, everybody. Thanks, John. Just like to talk about what's going on now with computer-assisted surgery and what we can do now and how we can prepare for the future. I have several disclosures, none of which really apply tonight. I will be talking about several different brand names. There are several devices which are FDA approved, and there's some that are not yet, and I'll discuss what I can. The big thing about this is we really need to think about how we are going to break through new barriers here. We would traditionally think of laparoscopes and robots, but then there's been a lot of thought as to what is going to work out best for our new technology. The way we're going to train is going to become radically different. We're not going to be sitting in classrooms anymore. We're going to be working with different simulators and practicing things on simulators. We're not going to be practicing on live patients. We're going to be undergoing several surgical skills procedures before we can even take care of someone. And as we continue on our trek from open to laparoscopic surgery, pretty soon we're going to be doing stuff like Dr. McCoy did, where we just scan them and figure out and it'll get fixed. There has continuing a lot of concern about how we're going to go in the future. We have these guys here that I think eventually are going to take over. Certainly Alexa and Siri are going to be doing a lot in the future. Some of the, oops, I don't know. Are you guys seeing my screen okay? I hope. The challenges we have are extensive. There are obviously training failures that we have to overcome. The cost of the equipment needs to come down. And the return on the investment for training has been a big motivator for third-party payers not to offer training. And we have to really take this into our own hands. We have different training centers that we run. The old way of doing this, as you can see in a lab with open, in an open situation or on cadavers, I think is going to change radically as we move towards more simulators. Another challenge we have here, as you can see, we don't have standards and benchmarks that require testing and evaluation, and how we're going to, as society, develop these expertise and partnerships with our device companies. What we do now is through the various models we have, using different robotic systems, practicing our hand-eye coordination, and I think there's going to be more of a hand-eye coordination test as residents and fellows come out. It's not going to be just based on letters that you receive from your professors, and how we take our robotic technology and we can do it in a reproducible way in our lab and assess your surgical skills. It's not going to be just see how many cases it tests. We're going to have to practice on simulators, and then we're going to see actually where your deficiencies and strengths arise in your ability to perform certain operations. Definitely there's going to be different challenges on how their skills are going to be optimized. Some people are see one, do one, teach one people. Some people need 50 cases. Some people are never going to be able to be trained at the end. And we have to be able to evaluate where the deficiencies lie and where the strengths are, and tailor our training to the psychomotor skills of the individual surgeon. It's not going to be everyone just raise their hand at the end of fourth year of medical school and say, I want to be a surgeon. You're going to have to be able to pass certain tests, and you're going to have to practice your skills. There'll be a variety of these simulators that we see. There's going to be certainly tying a knot. It's really scary how many surgeons that perform laparoscopic surgery can't even tie a knot intracorporeal. Sometimes with the aid of the robots we can do that, but these are some really basic things that we have to be proficient in before we can do our job. As far as surgical simulation, that I think is really the biggest area that's going to improve. We're going to be sitting down in front of a simulator. It's going to give us metrics. It's going to tell you what we're good at, what we're bad at. The OR staff is going to need to participate, and we're going to be developing new tools. This is where we've been through the years with some of the different robots through evolution. Some of you may be familiar with the Mimic Trainer, where we actually have to sit down and do a score. We're actually working on a protocol now through the Adventist healthcare system, where people have to give their results for the first 20 simulated cases before we'll grant them privileges for the robot. I think that's just the tip of the iceberg where it's going to come when it comes to this type of technology. I think it's a great idea to rehearse the procedure ahead of time. Say you're doing a robotic Whipple the first time. I wouldn't want to be the first patient on the table. I would want to make sure that the surgeon has gone through several simulations to know how to do the anastomosis. I mean, this would be a great thing for the lymphovascular transfer we just saw. So these types of simulators exist. There's several on the market. I think they all have strengths and weaknesses, but this is just going to continue to improve. And eventually, I bet it's going to be something that surgeons are going to even be able to do from their home. We want to match the surgical skill with the procedure. Here, in the case of another hysterectomy in a pig, you can see how they do the simulator, and then we can do it in the lab. And these simulators are going to continue to get better. The thing is, how can we extrapolate these training programs to the trainees, and how we're going to coach it? Feedback is going to be virtual, in person. However, I think a lot of these simulators are going to continue to improve since you won't have to travel to a training point, but actually can do it in your own backyard, essentially, and then watch people virtually. And these are just some of the challenges that we talk about every day. Certainly in quality assurance, we're talking about poor outcomes. How do we take someone that has had, say, 5 leaks, bowel leaks? We videotape them, and then we would put them on a simulator and see if we can identify where the strengths and weaknesses of this person. Is it the surgeon themselves? Is it a team challenge? And then we can correct that. And as I mentioned, there's just some listing of how the advantages and disadvantages of the simulators in the future are going to evolve. Telesurgery is a great thing. When Dr. Morosco did the first live telesurgery across the Atlantic, that was back on September 7th, 2011. Didn't gain a lot of popularity because September 11th, 2001 is when he did this. 9/11 occurred, and then that didn't propagate. The data connections when we do things virtually is very important, so we don't get a latency or lag. But this is how we do it on our own OR. We have a fellow and an attending. You can see their heads look a little different, but this is how we can practice and train, just like driver training. One person can be at the console, one person can be doing surgery. We can telestrate, just like John Madden does in football. We can do the same thing with the robotic surgical arms and screens. We are big believers in recording the video, just like in a sports thing. What happens? You review your game video, and you see what you did right and wrong. Why can't we do that in medicine? We should do it in medicine. We should do it in surgery. And that way we can see, sometimes in real time and sometimes through instant replay, what we did right and wrong, and do corrective action right then and there. So just a couple of videos here on what we're actually doing. Teaching in real time is certainly one way how we go about this. Practicing in the lab is another important thing. Here's some team training exercises on practicing docking and undocking a robot for an emergency situation. Very important skills that we need to practice. Here's another way we can practice in the lab. However, we also believe that training and simulation could also decrease risk. We've discussed this with our own risk management people, given the fact that we can say your first 10 cases, that's most likely when a lot of your errors are going to occur. Why don't we just do your first 10 cases in the lab, get your errors out of your system, so when it comes time to taking care of humans, you can do a much better job. Just want to show you a couple of videos on some of the newer robots that are coming out. I think these training patterns will be the same. This is the Senhan system. This one is FDA approved. It's been out almost a year here in the United States. It's been CE marked for a while. The modular type robotic system. A little different than the intuitive system. One of the things that can go through your existing trocars for minimally invasive surgery, and it does have haptic feedback. There is transoral robotics, which I think is going to translate into transrectal or transurethral robotics, and maybe there's even transvaginal robots that are coming out. I think this is a great tool, and this is just going to continue to get better as we move forward. This is an example of, as I said, a transoral one, this med robotic system. This is a new system that just has been FDA approved only several months ago, called the Oris system. It's a great video game, as you can see, but what this does, and this is how I think some of the surgeries in the future are going to occur, is where we can do image fusion, integrate the radiologic data into the robot, and then you really don't even need a surgeon. The radiologic data will guide the robotic arm to the point of the pathology with a little gain control there, you can see in the lower left. I think this will probably even be utilized as we go through breast surgery, just like in the last thing. What they'll do, will integrate, and I'll show you an example of something like that. Again, this image overlay. So you can actually, even though you can't see, quote unquote, where the arms are going, the radiologic data, as long as it's acquired properly, obviously that's the limitation, you can find where a biopsy of a tumor is and possibly do ablative treatment. Another type of robotic system is the cyber knives, and I think many of you have seen that. As an example, in a hard-to-reach tumor, using energy to ablate the tumor as opposed to excisional therapy. Just as warships shoot missiles out of the sky with energy, not bullets and guns anymore, it can implode a tumor. The intuitive system, which I think most people are aware of, that's certainly been out for 15 years and has a great head start and has really been the trend center as to what we are doing now. There is some of the, again, the image guided systems. I think this is really where a lot of this is going, where you can take the real-time acquired image, whether it be with CT or 64 slice CT in this situation, ultrasound, MRIs, taking that radiologic data, putting it into these robotic arms, gathering the tumor coordinates, and probably limiting the kind of resection margins that we need when it comes to cancer surgery to just taking out the bad area and leaving behind all the good tissue. I think in breast surgery, something like this is going to be coming on board, just as an example, where you get the precision of these arms as long as you have the proper integration of the radiologic data. I think we showed that med robotic system once before. Titan robotic system, where it's a single port type device. Example of how it was used in the lab. Verb Surgical is a combination of Google and J&J. This is going to be very interesting in the future, where the robotic surgical systems will actually talk to each other. They'll learn from each other, and artificial intelligence is going to become very important. How coordinating the precision and data points so we can learn from each other much better. Medtronic itself is also coming out with a robot that should hopefully be out within the year. We need to stay current. I think this is going to be a very rapidly changing field. There are several different organizations out now that will help train in robotics and give video feedback, again, through secure web servers where you can actually upload the videos and your skills will be scored so you can learn from each other. There's lots of different data analytics that'll help play to the outcomes as we move forward. There's certainly a lot of literature coming out on surgical skill and complication rates, how we can decrease this through video feedback and artificial intelligence and acquiring knowledge from robot to robot, surgeon to surgeon. So that's just a very quick overview of what is going on in the future. And now, hope that was helpful. And just like I said, just a very quick overview. There's lots and lots of cool stuff going on that I think is going to be very important for all of us in the college to learn from. And it'll be interchangeable, not only for us as surgeons, but minimally invasive surgeons, but as mentioned, possibility of ablative technology for breast surgery, and Ali, you'll probably use that in the future for some of your prostate surgery as well. Thank you.
Up, Dr. Ali Kasraeian practices in Jacksonville, Florida. He is an experienced open laparoscopic and robotic urologic surgeon. He utilizes high-intensity focused ultrasound ablative therapy for localized prostate cancer. He also has expertise in multiparametric MRI, ultrasound fusion, targeted prostate biopsy. So he's going to talk to us about advances in urology. Ali?
Well, thank you everyone for allowing me to participate in this wonderful webinar and to switch from all the general surgical and general advanced technology to urology. And what I thought we'd discuss is prostate cancer. The thing I wanted to kind of talk about are some things that are advancing the diagnostics and the management of prostate cancer, which is one of the most controversial things in medicine, I think, and screening for prostate cancer is very, very controversial. And how do we manage prostate cancer has been one of the most controversial things. And, to start with here, this picture is one of my favorite pictures I have. This is a picture of me and my dad, who I get to work with every day. And this is when I was a medical student in my first year. I got to come home for Christmas, and Dad was like, "Hey, do you want to come to the operating room with me?" I was like, "Sure." And I got to do a nephrectomy with him. And so now, as a grown-up urologist, I get to work with him every day, and operating with him is one of my most fun things to do. And one of the most interesting things I got to write was the ACS bulletin asked me to write about what it's like to operate with your dad. And it was probably one of the most difficult things I've had to write, and I actually wrote it right after I did a partial nephrectomy with my dad. So it's kind of like an interesting thing. So I kind of use it in all my talks. But the thing I want to talk about today is just a little bit of a brief overview about prostate cancer and the screening controversy and why the technologies I'm going to discuss today matter. And so I'm going to talk about the multiparametric MRI, which is an imaging modality that tries to look within the prostate and see if we can identify tumors and grade them with a system called the PIRAT score, which tries to mimic a bit of the BIRAT score for breast cancer, so that we can find tumors that matter, and then use this MRI ultrasound fusion targeted biopsy to actually target those areas. And then shifting from diagnosis to treatment, talk about high intensity focused ultrasound, which is a very, very minimally invasive ultrasound technique that we can not only treat the whole prostate, but use it to focally treat the area of concern. So basically do focal therapy of the prostate with the idea that if you, the more prostate you preserve, the more function you preserve. So you could potentially minimize the insult to the prostate and and not only have great cure of the prostate cancer, but minimize the insult. And I'll talk to you about how that may be a very, very important front to help change the controversy of prostate cancer screening. So prostate cancer is the most common non-cutaneous cancer in U.S. men, and it remains the second leading cause of cancer-related death. And if you look in 2015, almost 250,000 men were diagnosed with prostate cancer, affecting 1 in 7 men in their lifetime, and almost 27 to 28,000 men died of prostate cancer that year, 1 in 38 men. But fortunately, 2.9 million men at that point were alive and living with prostate cancer in the United States. So fast forward to 2018, still the most common non-cutaneous cancer in U.S. men, second leading cause of cancer-related death. But suddenly we have 164,000 cases, but 29,000 men are dying of prostate cancer this past year, and 1 in 9 men are diagnosed. But still 2.9 million men are dying. So how does this happen? So the U.S. Preventative Services Task Force in 2012, following several years of recommendations that were kind of in their testing phase, came out with a final recommendation, which was a grade D recommendation against screening for prostate cancer, which thought that the harms of screening for prostate cancer outweighed the benefits. And this really had some negative implications for us as urologists who deal with prostate cancer. And I'll show you how. So this fear of overdiagnosis of prostate cancer and overtreatment of prostate cancers that may not necessarily benefit the men who we diagnose really has plagued prostate cancer diagnosis and treatment in the United States. And I'll show you how. So the impact of this recommendations has translated into an 18% decrease in screening rates in the United States, mainly in the primary care front. 39% lower biopsies, and we're finding that we have less men diagnosed with prostate cancer. So the 35% of men with low-risk disease, it's unlikely to kill them, is not a big deal, but the 43% of men with intermediate or high-risk disease is significant. Other studies have shown this to be consistently true. A big study published in the Journal of Urology showed that almost 30% decrease in the new diagnosis of prostate cancer was spread across low and intermediate as well as high-risk disease. And this is important. The way I talk to my patients about prostate cancer is try to simplify it in terms of 4 types of prostate cancer. And I talk to them about rockets, rabbits, turtles, and snails. So rockets are metastatic prostate cancers that are out of the prostate at diagnosis. And that's really why we screen for prostate cancer, to avoid men showing up with metastatic prostate cancer, because that's fatal. Even in 2018 going on 2019, we don't have a cure for that disease. Rabbits are prostate cancers that have legs. If we catch prostate cancer that is of that intermediate and high-risk disease and we treat it, we could save these guys' lives. The turtles and the snails, those low-risk disease, those are the cancers that we can monitor with active surveillance, we could potentially not even find, and that's where all the controversies for prostate cancer screening lies, that historically we find those disease, and 90% of those diseases were treated and plagued with the side effects like incontinence and erectile dysfunction. And that's where we are today. The side effects associated with those treatments has led us to a place where we have made these recommendations, and in looking at this problems, we have found that the incidence of prostate cancer is dropping, but it doesn't mean that the cancer is not there. It just means that we're not finding it. So by withholding screening due to the concerns of overdiagnosis and overtreatment of this clinically insignificant disease, those turtles and the snails, we are now going to miss the opportunity to detect this more indeterminate, high-risk disease during the window that we could potentially cure them. So we got to think about a way to do better. So what should we do? The urologists are wondering, should we screen or not to screen? And more importantly, the primary care doctors are worried about this. So how can we do better? So one way we look at this is smarter screening and smarter treatment approaches. And the multiparametric MRI has been studied, especially in Europe over the past decade, and now, fortunately, over the past half decade, it's made its way to the United States as a better way for us to kind of look behind the screen of the prostate to look more deeply within the prostate to find areas that may harbor prostate cancers that if we find them, we could save lives. And this is basically like the title of it says, it's a multiparametric MRI. It's a multiphasic MRI scan that can find cancers within the prostate potentially, but it looks for changes in the characteristics of the prostate tissue over multiple phases to see if there are areas that take up and give up dye in a way that is more concerning. So the T2 weighted image may look abnormal, and then you can kind of see how it looks on the diffusion weighted images, the dynamic contrasted images. Some places use spectroscopy, and if it looks abnormal, we now have the technology that allows us to target this. So we look at this as to see why it's important. And you can see on these images how the images where the areas are that we could potentially target look different on all of these phases. And in studies that have compared this to prostatectomy specimens, they're really, really accurate. So here's why this is important. So currently, when someone has an abnormal prostate exam, or if they have an elevated PSA, what we do is do a standard transrectal ultrasound of the prostate. Then we do a what's called a systematic standard biopsy, which looks at the different portions of the prostate. And this mimics, if you kind of imagine it for a breast biopsy, if we took the breast and just kind of threw needles into the different portions of the breast, hoping that we caught something. You can imagine that this is plagued with inaccuracy. And again, overdiagnosis, underdiagnosis could be a problem. And here is the problem. We could potentially undersample the cancer that we want to find, and we could potentially oversample the cancer that we don't want to find. And you can see here in this image that we see here, you could have a very big cancer that these random biopsies miss, and on the flip side of things, we could potentially have a very small cancer that's clinically insignificant, and we may find that. So how can we do better? And the multiparametric MRI may allow us to do that. And now we have the technologies I'll show you to allow us to fuse the MRI and the ultrasound together to allow us a very precise targeting of tumors within the prostate. And I spoke to you about the PIRAD score. Basically, the PIRAD score is a 1 to 5 scoring system where 4s and 5 out of 5 are very, very concerning for a cancer. And I know in our own studies, which mimics national studies, we have about an 87 to 100% positive biopsy rate for a PIRAD 4 or 5. PIRAD 4 of 3s are between 40 to 50% positive, and 1s and 2s are less likely to be cancer. So you can make very good clinical decisions based on what the MRI scan shows you. So here's a short video showing us what this urinav system tells us. And so basically what this is, it's a combination of the MRI scan and the ultrasound that allows us to directly target into an area of concern. Basically, you have an MRI scan that's marked and imported, and you have an electromagnetic connection between the ultrasound and this technology that in real time finds the tumor on the ultrasound matched with the MRI scan to allow you real time targeting at the time that you're doing the ultrasound, matched with the MRI scan that's important into your system. So that you and the radiologist look at the imaging, either you or the radiologist can mark the region of interest, which is a 3D image. So you make a 2D procedure into a 3D imaging modality. And you can see that now you can find the tumor directly within the prostate and target it. You can also match it with a standard biopsy so you prevent error of missing anything within the prostate. And here's a short video of showing how that's done. And so here's a standard transrectal biopsy. And the nice thing about this is that from a workflow standpoint, this is exactly how we do our regular biopsies. And it doesn't really add too much time to the regular workflow of how we as urologists do this biopsy in our clinic. And it's not much of a big footprint in our clinic. We've done this in our clinics now for 5 years. And in terms of doing this, the important part is your relationship with your radiologist. In our practice, we're one of the first in the country outside of the NIH to bring the system into our practice. And we partnered with a team in the United Kingdom, which was very instrumental in beginning the MRI program from the radiologist. We partnered with them to get our protocols in place, and then we started the fusion program. And here's another image showing the same thing. So the idea with this is to get more clinically significant prostate cancers diagnosed, which allows us a more accurate risk stratification, and to diagnose more of those clinically insignificant cancers, which have been shown in study after study over the past several decades that they do not kill people. So multiple studies have verified the benefit of this algorithm of using the MRI scan and the biopsy. The first study from Peter Pinto's group at the NIH looked at more than 1,000 men over a better part of 2007 to 2014, and they found that the targeted biopsy compared to the standard biopsy diagnosed the same amount of men with prostate cancer. However, when you targeted into the region identified by the MRI scan, found more of those high-risk prostate cancers that you want to find, but fewer of the low-risk cancers that are clinically insignificant to the life of the men who you are doing the biopsy. So again, you're finding more clinically significant prostate cancer and less clinically insignificant prostate cancer. The second study out of England with a team out of Mark Emberton and Hasha Med Group, and these gentlemen are very instrumental in moving the MRI targeted biopsy movement forward internationally. And what they did is they actually matched the targeted biopsy with a templated biopsy, which is basically means that you do a systematic biopsy through the prostate in a few millimeters all the way through. So it's pretty much the most accurate way you can look to make sure the entire prostate is without cancer or with cancer. So short of a prostatectomy, it's the most accurate way you can see what's going on through the whole prostate. And what they found was for clinically significant cancers, meaning a Gleason 7 or higher, the multiparametric MRI was more sensitive at 93% than the standard transrectal biopsy, which was 48% sensitive. The other thing was that using an MRI triage system before a biopsy, 27% of patients could potentially avoid a primary biopsy, all the while finding less clinically insignificant cancer and more clinically significant cancers that you want to find. Again, the goals that we're hoping to do. Another study that recently got a lot of attention in the New England Journal of Medicine was what's called the Precision trial. Similar pathway. Randomized men who met criteria for a prostate biopsy were randomized to either do a standard prostate biopsy with a transrectal ultrasound approach or an MRI pathway. So they got an MRI scan, and if they were abnormal, they underwent a targeted biopsy, and if they were normal, they were just followed with routine follow-up. And what they found was, again, and this was about 250 men in each arm, they found that the men who underwent the MRI pathway, more clinically significant prostate cancer of Gleason 7 or higher was found in the MRI arm versus with a lower number of men with a clinically insignificant cancer, which is very important with what we're trying to do. However, in the previous trials, they found that the negative predictive value for this was about 76%. So could you potentially miss a small number of men who have a cancer that you don't want to miss? The way to bypass this is you could include a standard biopsy when you do the MRI targeting, and that's what we do in our clinic. So it allows you to make sure that you diagnose a clinically significant cancer, all the while not missing that 24-25% of men who may have a clinically significant cancer as well. Now, what do you do if you're diagnosed with a prostate cancer? How can we do better in terms of maintaining our minimally invasive options for the whole spectrum of cancer for men who may not have the most clinically significant insignificant cancer, but don't necessarily want a radical prostatectomy or radiation therapy because of the small volume of disease that they have? So how can we personalize prostate cancer better? So when you stratify risk for prostate cancer, you can have a low-risk cancer, you can have an intermediate risk cancer, you can have a high-risk cancer. Gleason 7 is basically our middle of the road cancer. And the Gleason score is basically the pathologist looks at the cells under the microscope and assigns a score from a 2 to 10 grading system. And 7 is a fence that divides those scores. 8, 9s, and 10s are more aggressive. 6s are a little bit less aggressive. So that's how we grade prostate cancers. And as you can see, there are multiple different options, ranging from active surveillance, where we can monitor those turtles and snails, from surgery with the prostatectomy, which the vast majority of prostatectomies are performed with a robotic technique, which is very minimally invasive, to a myriad of radiation therapy options, to some of the options with the ablation arm, which I'm going to talk about, including high-intensity focused ultrasound, which uses sound waves and ultrasound to destroy the prostate tissue, very much like using a magnifying glass to burn a leaf, which has a very, very, very good side effect profile with a 2% or less incontinence rate and about a 20% or less erectile dysfunction rate. And you can use this technology to do focal therapy. So the functional outcomes for prostate cancer are very important in this discussion. Prostate cancer surgery and radiation therapy actually have a very good cure rate, especially for low to intermediate risk disease. However, for most of the men, the thing that they worry about is the potency rate. And you can see in these studies here from the AUA, continence rates are relatively good, even though here you see it in a very, very well-respected group. They have a 65% continence rate in both the robotic and open arms, but the potency rate, can range anywhere from 26% to 49 to 63%, and anywhere from 28% to 81%. So there's a wide range of variability on here. Active surveillance is an equalizing discussion, and actually for the U.S. Preventative Services Task Force recently took us from a grade D recommendation to a grade C recommendation for screening because it normalized a lot of the cancers that previously we would treat, and now we monitor about 40 to 45% of those low-risk cancers, the turtles and the snails, that previously got therapy. And these are basically low-risk cancers, PSAs of less than 10, Gleason scores of 6 or less, small volume disease. And you can see even with that, through multiple different criteria for monitoring them. Good news with these types of cancers, more than 99% of the men who meet these criteria do not die of their prostate cancer, do not get metastatic disease. However, about 30% of the men who meet these criteria, on subsequent follow-up biopsies, their cancers do change where they may potentially need treatment in the future. So for these men, what is another option? So one of the things that we can do to further personalize their care is potentially learn some lessons from our mentor, Bernie Fisher, who looked at the world of cancer in a slightly different way and thought, is there a better way for us to treat breast cancer? Does everyone need a radical mastectomy? Could we potentially just treat the cancer within the breast and preserve the breast for women who may not need to lose their whole breast? And what he found in a study that changed the way we manage breast cancer in the face of a lot of controversy and the giants of surgical oncology was that you could. And good clinical studies can change the way we manage disease, where he found the segmental mastectomy with and without radiation therapy had similar oncological outcomes to the radical mastectomy in a study with a randomized clinical trial that changed the way we manage disease and really changed the world. We're doing the same thing in the management of prostate cancer, in a changing of the paradigm, with the idea that if you have a lesion within the prostate, and the MRI is changing this paradigm. So if you have a tumor we see with the MRI scan, if we can target it, and that's the only place that we have the disease, can we just treat that disease with a technology such as HIFU and leave the rest of the prostate alone, with the idea that the more prostate you preserve, the more function you preserve? And focal therapy may be an option for patients with low volume, low risk disease, as intermediate risk disease or low risk disease, or someone that may not feel comfortable with monitoring with an active surveillance protocol for a low risk disease. And there are very many different paradigms or protocols that we can do for this. So HIFU is a non-surgical, radiation-free outpatient procedure that is very quick, it's reliable, and one of the beauties of high-intensity focused ultrasound that is actually, we can repeat the same procedure. So it's the only treatment that you can actually repeat should there be a recurrence. So I'm going to show a quick video showing what this technology is, and if you can hear the sounds, this should be a way to help.
The SonaBlade 500 system is a computer-controlled device designed for transrectal delivery of high-intensity focused ultrasound energy to the prostate for treatment of prostate disease. Urologists have been using the SonaBlade 500 system to treat benign prostatic hyperplasia, also known as BPH, localized prostate cancer, and recurrent prostate cancer. The device makes use of integrated biplanar ultrasound imaging for real-time treatment monitoring, treatment planning, and pre- and post-treatment imaging of the prostate. Similar to what happens when sunlight is focused through a magnifying lens, precise focusing of ultrasound energy during HIFU treatment elevates the temperature of the tissue in the focal zone very rapidly, while intervening tissue between the transducer and the focal zone is kept at a safe temperature. The result is an accurate and repeatable lesion at the target sites that are monitored in real time by the treating physician. All the treatment zones are pre-planned and checked by the physician prior to starting the HIFU treatment. The imaging capabilities of the technology allow for identification of vital structures, such as the prostate capsule, seminal vesicles, rectal wall, and physiological location of the neurovascular bundles. The addition of an integrated Doppler feature into the transrectal treatment probe adds an additional safeguard during treatment. The integrated Doppler feature will assist the physician in the identification of vital structures that need to be preserved in order to avoid problems with urinary continence and sexual function.
So, and here's an example where you show a patient before and after therapy. So you can see there on the top left, someone who had a lesion of concern that was targeted to be positive for a prostate cancer, and then a 1 week following hemiablation of the prostate with high intensity focused ultrasound, and an MRI 6 weeks later that shows no evidence of disease on that portion. So you can actually then monitor with MRI scan, and studies that have been done that show follow-up biopsies show very good results, as I'll show you. So the initial studies in 2011 by, again, Mark Emberton and Hashamed's group showed in a phase 1 and 2 trial that 89% of men achieved what's called the trifecta of pad-free, lead-free continence, positive maintenance of erections, and cancer control at 12 months. Another study published in Lancet showed the same trifecta in terms of cancer control, continence control, and maintenance of erections. And a most recent study that was just published in European Urology this summer followed patients undergoing focal therapy in a multi-center study looking at more than 600 patients for 5 years. And they found that 5-year outcomes for men undergoing focal therapy had a 98% metastasis-free survival, 100% prostate cancer-specific survival, and a 99% overall survival. And what's amazing about this is that 84% of the men who were included in this trial, had intermediate or high-risk disease. Typically, right now, when we're selecting patients for HIFU, whether it's a whole gland or a focal therapy, they're usually high-volume Gleason 6, meaning low-risk disease, or low-volume intermediate-risk disease. So they push the envelope for these men from that standpoint. The other thing from the standpoint that was interesting is that these men, 88% of these men underwent focal therapy, and at 5 years had failure-free survival, meaning that they did not undergo any other secondary therapies. And when you compare this to 3-year biochemical progression-free survival for men undergoing robotic and open radical prostatectomy, you can see that the results are fairly similar, as this study shows from the AUA. So focal therapy is safe. It's got very good functional outcomes with a low probability of urinary and rectal side effects, as well as erectile function results. And it's got very good effective medium-term oncological proven outcomes in comparison to surgery and radiation therapy. And it can be offered to select patients with non-metastatic prostate cancer who, especially if they are people who are very, very focused on their quality of life outcomes, or people who are candidates for active surveillance who may not be comfortable with the idea of monitoring a cancer that they know is in their prostate. And there are patients who the anxiety of active surveillance, which means PSAs every 3 to 6 months and repeat biopsies every 12 to possibly every 12 to 24 months is a bit much for them to take. And this is a wonderful, minimally invasive option for them to consider. So it allows a further, very minimally invasive option to personalize prostate cancer for our patients from diagnosis to therapy. And it follows, a paradigm shift that Bernie Fisher led to us in the management of prostate cancer. I personally want to thank my mentors in allowing a thought process shift from when I started my fellowship in Paris at the Montsouris Institute in 2007, where the gentleman on the far right, Eric Beret at the Montsouris Institute, introduced me to the idea of high intensity focused ultrasound. And then I met Mark Emberton there and Claire Allen, who introduced me to the idea of the multiparametric MRI, and Dr. Cianti in the middle there, who introduced me to high intensity focused ultrasound and focal therapy. And then Joshua Lennon, my first radiologist. With him, we built our MRI program here in Jacksonville, and Peter Pinto and his team at the NIH, who helped us get our first urinav here in Jacksonville and get our program started. So thank you guys very much. There on the right is Guy Valencian. He was the chairman of our program in Montsouris in Paris. He actually did some of the first robotic prostatectomies here, actually the first one here in the United States with Manny Menon up at the Henry Ford. And he was a very, very wonderful guy. His big thing in life was to balance work and play. And again, obviously my father for letting me a little bit of a loose rein to kind of do these things in a two-man private practice. So thank you very much.
Okay, so I want to thank all of our participating faculty. We have a couple of questions. First one, I think, is probably for Dr.
All right, it looks like all faculty mics are on. Dr. Rioux, would you like to field a few questions?
Yes. So with
your mic is on.
Okay, you hear me? With the UroNav system, do you speculate the next generation will allow for tumor resection under live imaging?
Well, it's interesting, actually, with the UroNav system, there are multiple different systems for the urine. There's a UroNav, there's the Artemis, and a whole slew of new machines have entered the market over the past 2 to 3 years to allow MRI fusion technologies. The HIFU systems, there are two HIFU systems. There's a Sonoblade system, which is a US-based system, and there's an EDAP system that's based out of France that has two basically systems. One's a focal one, and the other one is basically their original EDAP system. All of those systems have allowed for an integration of the fusion technology, so that whenever we identify a lesion on MRI scan that we've done a targeted biopsy, we can import our targeted biopsy images from our biopsy into the HIFU system, and then we can then target and biopsy treat our biopsy lesion. So we actually, I call it high intensity or intensity modulated high intensity focused ultrasound. I haven't published it to coin it, but it's basically the idea that if you have a targeted lesion that you're going to do focal therapy, you now have the lesion that you can target. Whether you do a focal therapy or even, let's say we're going to treat the whole prostate, you can potentially double treat the region of interest that your MRI targeted. So we can now really focus on that area, and the MRI images, instead of guessing that it was that area, we can now target it. We've actually done a lot of studies also to figure out how big our margin needs to be. Multiple studies have looked at between 9 millimeters and 1.2, 1.3 up to 1.6 millimeter margins. So we were spending a lot of time making sure that we have enough of a margin to minimize in biopsy recurrence rates after focal therapy.
Very nice. Let me go on to Jay. Jay, in simulation training, who are the expert reviewers, or who will be the expert reviewers, and can that impact a person being hired? Should it be used to determine if a trainee progresses to the next training level or even graduate residency?
Well, yeah, that's a great question, John. The right now, to be a qualified reviewer, I should say, you have to be performing at least 20 robot cases per year, and the trainer needs to submit their videos as well for, actually it's crowdsourced review. It's a little controversial, but as we move forward, actually the computer itself and the algorithms that are generated by what is called a successful surgical procedure Actually, the computer is going to, and the artificial intelligence is going to be grading you in the future. What it will detect is lack of blood, economy of motion of the robotic arms, precision of dissection, and identifying certain anatomical planes. This is actually it's in evolution as well. But as we move forward, I think the computers are actually the ones that are going to be grading it. You'll upload your video, it'll scan the procedure, and it'll tell if you're doing a good job or bad. But that is the way I think things are moving in the future. Just as Ali was talking about the prostate biopsies, I think what's going to happen is the computer or robot is going to do the biopsy. You'll upload the radiologic image. The robot will place the identification arm. It'll biopsy the tissue. It'll identify the tissue by spectroscopy or instantaneous microscopic analysis, and it will do the ablation all in one fell swoop.
Fascinating.
Not going to need a surgeon in the future, I think, unfortunately, but that's, I think, real.
I think we'll be needed somewhere. I don't know where, but somewhere.
It's going to be different the way it is now, that's for sure.
So, Nick, is there anything that you see coming down the pike for general surgeons in private practice in utilizing, for example, reverse mapping when they're doing their axillary dissections so they can avoid, injuring lymphatics? Is there something that will be relatively available for most trainees going out into their practices in the next few years?
Yeah, excuse me. Yeah, absolutely. I mean, I think one thing that we're going to have to really carefully look at moving forward, and a couple of groups have started to look at this, is really understanding the concept of nodal preservation. So not involving someone like me to do a lymphatic reconstruction at all. So is there a role in preserving arm draining nodes relative to taking the breast draining nodes? And so there is some capacity to do that now, and we've looked at that. We're actually starting to trial doing just that, but there certainly is a concern in doing so of having an increased risk of recurrence. We know that a third of those nodal basins have cross drainage, and so understanding, really having a detailed understanding of who those at-risk patients are that have cross drainage, or who can safely have arm nodes preserved, reverse mapped and preserved, it is certainly something that's going to be critical to the breast surgeon looking to minimize the risk of lymphedema in patients. We know that a couple of groups have looked at this early on, and what's worrisome is while it's not super high, we've noticed a little bit of an early increase in recurrence rates in those groups who have been preserving some arm draining nodes, and I think it's certainly related to some of that cross drainage that we don't have a firm grasp on yet between those nodal basins. So I think getting a better understanding of that, and once we do, being able to successfully identify patients and preserve nodes when appropriate will certainly help from the breast surgeon standpoint. Alternatively, I think that the microsurgical techniques are something that we're going to be able to expand in the future as well. Having these coordinated efforts early on, we faced our challenges, but certainly we've gotten more and more efficient at coordinating these team efforts, where I'm involved with the breast team there at Moffitt, and we just get these patients who have known axillary disease, who are going to be undergoing nodal extirpation preoperatively. We just coordinate those cases, and we really got quite efficient at reestablishing their lymphatic drainage at the time of their axillary dissection as well. Eliminating that risk or that concern of, are we putting a patient at risk for recurrence by preserving some of those axillary nodes? So I think both are worthwhile things to be investigating moving forward, and certainly that's what we're doing right now.
Okay, well, I want to first of all thank the attendees. I know we went over a little bit. We knew that we probably would with three very interesting topics like this. And I'd like to thank Dr. Kasraeian, Dr. Panetta, Dr. Redan, and the staff at the Florida chapter for putting this together. So thank you all, and good night.